Good morning, everyone, respected dignitaries and my dear friends. I'll be speaking on, I should thank Dr. Veena for giving this opportunity to talk on figuring out the pattern deviations. I have no interest in this presentation. So let's start with this case. A 14-year-old girl presented with complaints of outward deviation of the eye since childhood. On examination, we saw she had no abnormal head posture, but the visual acuity was 6/9. On examination, we see, what do we see is there is a exotropia, and when we see the up gaze and down gaze, there is a different deviation, and this is what is known as V-exo, or what we call as the pattern strabismus, and this is very commonly seen 15 to 20% in cases of horizontal strabismus. And very common in our scenario is the V pattern, where the A pattern are more common in the Western scenarios. So V pattern is known as when the exotropia is more in the up gaze, and A pattern if the ESO is more in the up gaze. So you can have X pattern, Y pattern, lambda pattern, or a delta pattern. Now look at this patient who is almost exo in the primary gaze, and it's the deviation it's not more in the down gaze, but when he's looking up, you see that the eyes are going out. So this is the typical Y pattern exotropia. So how do we go about doing a clinical workup for these patients? They may be coming to you with complaints of asthenopia, or there can be a difficulty in reading in these patients. When they walk up to your clinic, best thing is you should look for any abnormal head posture, whether they're coming up with a chin depression or chin elevation in those cases. And very important, you have to see all the 9 gazes to find out and see what type of a pattern it is. Very important is you have to look for over elevation or depression in the adduction, where you have to find out whether the oblique dysfunction is there or not, because the management depends on that, whether the obliques are affected or only the horizontal muscles are affected in the various gaze. So coming to the measurement, we do a measurement with accommodative target both for distance and near, and if the patient is having a corrective glasses, you put that on, and the difference of deviation measured in 25-degree up, that is chin down, or in the 25 to 35-degree down gaze, if you see that the deviation is varying for more than 15 prism diopter, it's a V pattern, or more than 10, it is a pattern deviation. Assessment of the fundus to look for torsion is very much important, and that you can do by indirect ophthalmoscope, or you can do a fundus photography, and that is the paper I'll be talking on, where the torsion is getting affected when you don't consider in AV patterns. So why do this happen? So there are certain risk factors. Patients with craniosynostosis, with spina bifida and superior oblique palsy can have a V pattern, and you have to be very careful. Infantile esotropias with E pattern, and thyroid patients who have had a surgery of inferior rectus are more prone having this A patterns. So coming to the etiology of this pattern strabismus, we know there is a mechanical hypothesis and neural hypothesis, and lot of extra ocular muscle pulley by Dimmer has been talked about. So what I am going to stress here on 2 things, that is abnormalities of the muscle insertion, talking about the sagittalization and desagittalization based on the superior oblique insertion, and anomalies of the muscle pulleys. So when you have a pattern in orbital configuration, it's very important. You have to be very careful, because they are the complicated cases of different pattern deviations. The older theory of horizontal school or the vertical school is no more abundant now. What Knapp has popularized, the oblique muscle overaction, is taking into account. A V pattern is a primary or secondary overaction of the inferior oblique muscle, leading to increased abduction, which especially when the eye is in elevation, and that is why you see this V pattern. And when you are now look at this patient, and if you see this patient, there is a exo, but what do you see? It gives you a pseudo inferior oblique overaction, and when we asked for a MRI, the patient had a orbital structural anomalies. So you have to be careful when you are dealing with Cruzen's Apert syndrome patients, because the V pattern in this craniofacial syndrome will vary, and you just manage doing a oblique will not take care of the pattern deviation in those cases. Coming to the muscle pulleys, downward displacement of lateral rectus pulley in V pattern has been given, and so in these cases MRI scans are needed to find out. Well, the management is basically aimed if the difference of angle of deviation in up gaze and down gaze is more than 50 prism diopter, or the squint is interfering with the ocular stereopsis, or a patient is having a significant abnormal head posture. General principles: if the deviation is very small and you have to give the corrective glasses, go in for amblyopia therapy, but surgery is a must for AV patterns. And then you have a choice. Very important, look for the oblique dysfunction. If you have an oblique dysfunction, you have to tackle the oblique, otherwise it will not take care of the deviation which you are having. So this is an example of V pattern. So suppose you have a oblique dysfunction along with the horizontal dysfunction, then weaken the inferior oblique, go for recessions. We have different recessions. And otherwise, if the oblique abnormality is absent, go for vertical disposition. And this we have learned very much. MR has to be towards the V, and lateral rectus is away, so you have to mark that up and remember. Horizontal surgery for primary deviation has to be done, and if you have associated DVT also present, anterior transposition of the inferior oblique is a must. How much surgery should we do? So horizontal muscle resection, it depends on the deviation in the primary position, and that you know as per from with your hands how much it is coming. Collapse of the extent of AV pattern, weaken the obliques with its 20 to 30 prism diopters, differential R&R 20 diopters, and slanting reinsertions around 15 diopters. You can go in for a half tendon vertical displacement or full tendon vertical displacement. Now this is an algorithm which is given of how you are going to take care of VESOs, AESO patterns, and main basic fundamental is remember whether the obliques, or if you have a AESO with a superior oblique overaction, then weaken the superior oblique, it will take care. And these are some of the studies which are there, and this is by Rosenbaum, which has showed how the A pattern with superior oblique has given a good result, and they are now talking about this V pattern in cases of craniofacial dystosis, where it is a complicated surgery and you have to be careful when which muscle you are handling. Anomalies of muscle insertion is very important, and you should understand this plagiocephaly, why there is the insertion of the superior oblique, which is more that is taking giving you a superior oblique overaction in those cases, and you can go in for a superior oblique expander. Taking care of the torsion, which also results in AV pattern, and better to do a posterior tendectomy of the superior oblique in EXO to avoid the diplopia which will be associated. And this Kekunia has all had written a paper on pattern strabismus and torsion with special reference in surgical attention, and very good the review is on. And Dr. Pradeep Sharma himself has talked on torsional changes in surgery for AV pattern in 1997, where he saw that there are some cases who give rise to torsion even after taking care of the surgery. So this is a patient who presented to us with a V pattern exotropia. If you see, it is around 30 in the primary gaze, and it is increasing to 45 above and 20 in the down gaze. We went ahead and just did a lateral rectal decision with full tendon, and this is how she has primary positions is okay, but superiorly there are still some type of a exo, but she's doing well. So the take home message is very important. Where is the functional gaze, that is the primary and the reading positions. Large AV pattern are associated with oblique dysfunctions. So inferior oblique weakening or superior oblique tuck takes care of 15 to 20 prism diopters of V pattern. Bilateral superior oblique tendectomy 35 to 45 prism diopters A pattern. If you don't have a oblique dysfunction, you can just tackle the horizontal rectus with a transposition. You have to take care of, especially for X and V patterns. V patterns, you have to very careful look whether there is a pseudo inferior oblique overaction, or you have to just take care of the lateral rectus. Be careful about the pulley mechanism which will be there, and just tackling the lateral rectus in those cases can remove the V pattern. Complications you should keep in mind. You don't want a iatrogenic superior oblique palsy or a torsional diplopia in these cases. So thank you for your patient hearing.